developing a system of changing our organization from being trauma aware, just knowing that trauma exists, and at times possibly re-traumatizing patients with the ways that we practice, to being trauma informed. And it's important to recognize that specifically our intervention is geared at being trauma informed, not necessarily being a trauma healing organization. So when we think about being trauma healing, that's all of us here. That's our behavioral health team. We treat trauma. Trauma-informed care is not about teaching our pediatricians or our front desk staff or our nurses to treat trauma. It's teaching them ways that they can engage their patients in ways, our patients, that are not traumatizing, but also increases the awareness of how trauma manifests for our patients. Maybe when they're at the front desk, when they're getting angry, asking that question that we talked about earlier, instead of what's wrong with you, what happened to you? And so in doing this trauma-informed care approach, there were a couple of different ways that we distributed the information. The first was my team as well as myself presented at the big meetings, executive meetings, and in White Plains. Anybody have attended those meetings? It's a drive, right? The breakfast is good. It's warm, but it's early, like 8 a.m. in White Plains. And so I was slated with talking about trauma-informed care at 8 a.m. Yeah, I was like, really? That's what we doing? I think I might have been like 8 months pregnant at the time. I'm 5 months pregnant now, so this feels like flashback of those times. And so that was the first thing, and it was really about creating buy-in from our leadership. Because for all of the interventions that MMG does, you can have a great idea on the ground level of your clinic, but unless somebody, the CFO or the CEO or someone's boss says you have to do this, it's only partially successful. Would you all agree? So that was the first part of the rollout. The second piece is we wanted to distribute the information on the site level. So we developed training specifically for certain sites. And the reason we did this, and this is the 2.0 part, the reason we did certain sites is we wanted to be able to compare and contrast pre and post. Was the information helpful? Did it help our staff become more trauma informed? And there were specific things that we were looking at. Their awareness of trauma, patient satisfaction, screening specifically of ACEs universally from birth to geriatrics. And so we really wanted to see what role having these specific site trainings did in helping educate our staff. The other piece is we did a talent management rollout. So all of our staff that were employees at the initial rollout of the program were all assigned modules that modeled those same trainings that were done in White Plains. And so that brings us here. So after that rollout, all of the sites in Wave 1 received the training. Now we're at the point that Wave 2 sites need to have the site-specific training. So what we're going to do today is I'm going to teach you all how to do the site-specific trainings. If you were handed a folder, that means that you're going to be a trainer for your site. If you weren't personally handed a folder or personally told you need to get a folder, that means you're going to be a backup trainer in case someone here isn't able to train. In the middle of the table, these are folders for backup trainers. I'm going to send all of this electronically, but I invite you to take a couple, share it with your peers. It's not enough copies for everyone. It's a lot of paper, and we don't want to kill a lot of trees. That's why I don't have 1,000 copies today. So there are folders distributed at random points in the room, and you're welcome to just pull from those folders if you like. But if you're specifically a site trainer, you need to make sure you have a folder, and I'm going to orient you to that folder now. Any questions so far? Has that been clear?
Is every site represented?
Yes, every site is represented. I'm going to read out specifically, just because if you're curious, if your site is in Wave 2, I'm just going to read them out. If I don't say your site, that means your site has already received the site-specific trainings. So I'm at CHCC. CHCC people that gave those trainings in 2016, raise your hand. I know Maritza, myself, where's Maritza? Evelyn. Yeah, so we gave I feel like Suzanne gave some of them. FCC already did the trainings. Is FCC represented and gave some of the trainings? No? FCC? Did anyone at FCC give the trainings and talk about ACEs and give those? No?
No.
Okay. Oh, no one's here from FCC. Okay.
No, here.
Then I'm saying that was here then.
Yeah.
That was here then. No one was there then. Okay, so if your site has already received these trainings and you're at that site, but you weren't one of the people that gave the training, part of the reason it'll be really good for you to be here today is that your site is already using some of this language and has been on board for several years in trauma-informed care. And so I think it's very important for the behavioral health providers to be able to have that shared language. The next stage after we finish this level of training is to do another MMG-wide training that's really focused on sustainability. How do we onboard new people? So, you know, you may have heard these terms, but you started a year ago, and like, how do you get trauma informed? And so that's the next phase that we're gonna focus on. But today, it's about finishing up that initial cycle, making sure every site has had that initial training. So the sites that are having training for this wave are Astor, Co-op Bardo, Cross County, Eastchester, Family Health Center, Grand Concourse, Marble Hill, Riverdale, University Avenue, Wakefield, and Williamsbridge. Does everybody from those specific sites have a folder in their hand?
No.
No. Okay.
So the social workers at FHC do not?
They're on the list. That should be.
It's Raquel, it's Fred, it's Joy.
Okay. You have one? Okay. Anybody need a folder that's at one of those sites? Everybody else got one?
Fred, you got one?
No.
Can you reach the folder right there? Right there. Anybody else? Okay, so now any other folder is extra if you want to follow along, okay? So I want to orient you to your folder. So if you open it up, I'm going to stand right next to you, Fred, because I see you listening. So Fred and I are going to open our folder, and if you notice, there are quite a few sheet protectors. And the reason I specifically put the sheet protectors this way is that they're made that you can just simply pull out the sheet protector and place it on the copy machine. So you don't have to unstaple anything. You don't have to like, oh, what exact sheets do I need? On the front of each packet, it says exactly what's in that packet. And then you just pull it out and copy it, okay? So the first for today is our training materials. This is what we're gonna be using today, and that'll just be helpful as you do these trainings. The first is the agenda. That's just the agenda for the training. That's where we're at. So what we're gonna do, we did our welcome, we did our introductions. I'm gonna present one of the trainings. Alyssa is going to talk about how to give effective presentations, and then we're going to practice giving some of the presentations. Then we're going to do a wrap-up, okay? That's the first sheet in there. The back of that is a trainer feedback form. You're going to need that later when you practice giving some of the trainings. And so what's going to happen, anyone that is not giving a training is going to give feedback, as well as you're going to use this form to see if there are ways that you can improve your training, okay? It'll make sense when we get to that point. Then there's a handout on how to print PowerPoints with notes. You likely won't need this, but just in case, I put that in there. And then finally, it's a handout on how to give effective communication. Dr. Mallow is going to go over that in a bit. So that's your first packet. The rest of the packets are duplicates in some ways in that they have slides, hypothetical materials, and resources in them. So the way that the trainings go is at each site, based on the specific role, those people are brought together and given a training. So nurses together, PCPs and MPs together, PSRs and administrators together. The reason we use this approach is because we really want to create a safe space where there's not a hierarchy of authority. Now we recognize that PSRs and administrators, sometimes that is that hierarchy, but they're oftentimes dealing with the same type of patient experiences, which is a person who's agitated or upset, and so they need a similar skill set, and it just wasn't enough administrators and enough PSRs to have them away from the desk to necessarily have them broken up separately. But all the rest are specifically broken up by their role. The other thing that's different specific to the role is the detail of the information. So today I'm going to present the most detailed of the presentations, which is the PCP MP, that goes into some of the brain knowledge about trauma. And then the PSRs go more into how do you de-escalate a patient and doesn't necessarily go into like epigenetics. There are some rare circumstances that your site is so small that you'll have to do a combined training, that it doesn't matter what your role is, that you're going to do a general training together because maybe there's only like 9 people there. If that's the case, we're going to specifically let you know that and email that material. We try to avoid that because we want that hierarchy to be diminished and we want people to have a chance to get to know each other and to talk in ways that are specific to their field. What's going to happen after this training is our graduate assistant, Ms. Lopez, is going to send out a schedule for when your training is going to be at your site, what location, and the time. Okay? Questions?
For site administrators, do they know this is happening?
They do. They're very aware. It's been a 3-year process. Some of them have said, well, how come we haven't had our training yet? CHCC got their training 2 years ago. So they're aware. And they're working with us to pick the schedule and all of that. The trainings will take place between August and November. So it'll take some time because this is time that people aren't in the clinic. The presentations are about 45 to 60 minutes. Okay? So if you look at the next couple of packets, you'll see slides and handouts, what that specific population is, and then what's in there. And again, and I'm looking specifically at the PCP and MP, because that's what I'm going to cover today. I pull that out. It tells me what's in there. I walk to the imaginary copier, take the, hey copier, you're working today. I take that front slip off, and then I just put this on the copy machine. They're all copied front to back, and there's 2 slides per page. There are only 2 slides per page because all of your sites aren't necessarily going to have a projector, right? And you don't want it to be, the print to be so small with 3 slides because it's not accessible across all everyone's vision level. So we have 2 there. At the end, there's also resources. So you just place this on the copier. You know how many people are going to attend. You know your clinic. That's information you'll get from Ms. Lopez. And you print on there 10 copies front to back, staple it, carry it with you. Okay? So that's the material you need specifically for the people who are receiving the training. The next thing that you need for yourself is what you're actually going to say, right? So the last packet is called Slides and Sign-In Sheets. So you'll say, hey, I'm doing a PCP training today. You'll open this packet up. And the very first one that is stapled, this is the only time you have a staple and you don't need to remove the staple, is the actual presentation you'll give with the notes. And these notes are written so you can read them verbatim, if you'd like, all the way to the end of the training. No, so each copy is a different training. So the first one is the PCP, the next is the PSR, the next is the LPN, and then it's a hypothetical patient scenario. I'll talk about that. And then there's your sign-in sheet. You're gonna have to, this is why it's single, you'll have to Xerox this so you have multiple sign-in sheets if you have multiple trainings. Say you have to give 3. You'll need 3 sign-in sheets. After your training, you will send this copy of the sign-in sheet either with a PDF scan, or you can send me a picture, or you can type it up. Please don't type it up. You got so many other things that's not working to the top of your degree. You're gonna send this so we know who attended the training, because it is a mandatory training for all MMG staff. Questions about that? Pretty straightforward, right? Okay. Does that sound pretty easy? I tried to make the copies as seamless as possible. Last time we had stapled and people had to take it apart, and that's too much. We have a lot to do, right? So now I'm going to give you the actual presentation of the PCP and the MP, so you know what to say. Now, I will say that I think throughout my life, I've been a pretty good presenter. I'm not going to be ad-libbing a lot today. I'm going to just like give the presentation based on the words that are there. There's a couple of things that I want you to be thinking about as I'm giving this presentation. Number one, I'm going to speak faster than I normally would because you're going to be reading along. And there's two different mindsets that I want you to have during this presentation. One is understanding the information, and two, how am I going to deliver this information? So you're going to have to be multi-minded. As you're listening, I would like you to figure out some ways, how would you make this your own? So some of the words that I put in there and maybe some of the jokes you just might not think are funny. Like you didn't think an imaginary copier was funny. That might not be something you say. Make it your own, okay? The other thing is really pay attention to if you like a slide a lot and there's a point that you want to emphasize that feels particular to your clinic, write a note for yourself. So in that packet, that's that last packet, slides and sign-in sheets, take this out and follow with me. Write down your notes. What are you going to say? How are you going to emphasize certain things? The other thing I want you to pay attention to is any slides that you feel like you need to practice. Maybe saying the word epigenetics doesn't flow off your tongue. Maybe doing mindfulness with a group of people isn't something you feel good at. When we break up into our groups, you're going to be asked to practice 3 slides. So I would like you to identify those as I'm speaking so then you know what 3 you're going to practice. Does that make sense? The other thing is, what are some things that if you start your presentation late, because a lot of times people will be late and clinics are busy and people are running behind, what are some things that you felt like, you know what, that point was way too like detailed? What can you feel like you can just kind of rush through and you don't have to say every single word? So you're going to be listening to all of that and keeping that mindfulness in mind as I go through, as I go through the training today. So before I begin, are there any questions? Okay.
How late can a person actually come into the training once you start?
That's a great question. I think it depends on like how like is it everyone in the room? You don't want to start like 20 minutes late and it's a 45-minute presentation. If someone comes 5 minutes before the presentation and you don't feel like you can say, well, you're late, Dr. So-and-so, so you need to, because, you know, that's kind of awkward. Use your best judgment. There's no set rule. Most people are interested in trauma-informed care, so they don't feel like, oh, I have to go to this training. But some people feel like they do, and we're not trying to traumatize people by making them go to the trauma-informed care program. So it shouldn't be a terrible experience for them. And most importantly, it shouldn't be a terrible experience for you. We appreciate you participating in this. You know, the goal is to help everyone serve our patients better. If they serve our patients better, they're less angry when they come to us. We're more effective. Like, it just is a better experience for us as BHIP providers. You're not there to have to go through a whole, like, why is trauma-informed care? You don't have to sell the program. Do the program, do the presentation, keep it moving. If you have any resistance or concerns and you need support, please reach out to me, okay? All right, so this is specifically PCPs and MPs. I'm going to send this electronically in case you're lucky enough at your site to have a projector. So I would start the presentation with the talking points if you look at the notes. And so in all of the electronic handouts, the electronic ones I'll email you, there are notes on the bottom of each slide, just so you know. So I'm going to start off by saying, good morning. Today I'm going to be talking about MMG's Trauma-Informed Care Program. We hope this is not the first time that you've heard about this program. We have about an hour together today to complete this training, and I want everyone to participate. That being said, I apologize in advance if I interrupt you. It's not because I'm being rude, but it's to keep us on track and get through the training. Our topic today is not only about understanding what trauma is, but also about learning about the manifestations of trauma And if some of the material today we talk about triggers you regarding your thoughts or your feelings, we've provided some resources and some confidential behavioral health services that are listed at the end of your handout. Then we have some teaching points that you may choose to attend to or not if you have enough time. So it may be if the site, for whatever reason, for our backup trainers, isn't a site that you work at, you want to introduce yourself, you may ask people to introduce themselves. You have an optional activity here that if you're leading a training at your clinic, that you may have people go into like a icebreaker similar to like what Katie did this morning. So then we have our learning objectives. I'm here to talk about how chronic stress and trauma affects us as human beings, how that may affect our health, our behavior, our interactions with our patients, and our work. This training is meant to supplement the talent management training modules that you've been assigned from 2016 up until May of 2018. Today's training is broken into two parts: understanding stress and trauma and the manifestations of trauma. Our learning objectives are to create a shared language, because the word trauma is often defined in many different ways. We also want to provide you with some tools on how to interact with patients who may be displaying traumatic symptoms, to learn about epigenetic manifestations of stress and trauma, and finally to understand burnout, compassion fatigue, vicarious traumatization, and how they affect you. We want this training to be as interactive as possible, so don't be shy, please ask questions. We're going to start with a short activity. You should be at about 5 minutes at this point. And so throughout the handouts, they tell you kind of a benchmark, okay? If you start at 5 minutes late, you might go through that beginning spiel a little bit faster. So one teaching point is you can ask people, this is a patient, Josie Garcia. How many of you would call Josie, Josie? Nobody would call Josie, Josie? No? 2 people. How many would call Josie Miss Garcia? And the rest of y'all wouldn't take this patient? You just not gonna take the patient? Okay, or ma'am, or miss, I don't know. So that's an interactive. You can ask people, what do you call your patients and why? 18 is right on the gap of adult and child, so depending on the practice, they may use Miss or Josie. So I would like to introduce you to Josie. This is a combination of a variety of patients, not a specific patient. Josie is 18 years old and she lives in a 1-bedroom apartment in the Bronx with her mom, sister, and 2 nephews. Josie has type 1 diabetes, is non-compliant about monitoring her insulin levels, and was taken to the ED for passing out. After reviewing the ED discharge summary, you explain to Josie that her blood work indicates that her diabetes is currently not being properly managed. She rolls her eyes, shakes her head, and says, "Are you going to lecture me again? Because I am not going to stick myself every day, so save your breath." When you explain that not monitoring her insulin levels is very dangerous for her, and tell her that you want her to see a diabetic nurse, she refuses to accept the referral. Does this sound like any patient that you've ever interacted with before at MMG? Yes? So this is very familiar. And so that tool, asking people, does this sound like your experience? Sometimes when you're in a more intimate setting, people might laugh. They might go, oh, definitely. You want to engage those kind of responses. On your handout, and again, there's 2 slides per handout, I want you to fill out some responses. The first asks you, how would you feel if you were the provider in this scenario? Please circle all of the emotions you would feel if you were the person interacting with Ms. Garcia. So someone might say, what's an emotion you might feel? You can call out. Frustrated, angry, what was that? Overwhelmed, worried, maybe paralyzed, sad, agitated, riled up. The second slide asks you, what do you wish you could do if you were this provider? Maybe some people might wish they could walk away. Maybe some people wish they could assign somebody to come to her house every day and stick her and take her blood sugar against her will. Maybe some people would just say, hey, that's her business. If she wants to have a diabetic coma, that's her business. And so you're going to say something like, I want everyone to feel safe and safe enough to answer honestly, and this information is not going to be collected. And so you'll give people a few minutes to respond to those slides, to slides 3 and 4. And you'll base how much time based on if they're like circling, if they're not, if they're engaged, if they're rolling their eyes at you. You might keep it moving. If they're really engaged, this might be an area that you choose to emphasize because it kind of warms up the scenario and it just honors the experience that a lot of us have had. The cool thing about doing this training is it's often a great time to connect with your team in ways as a trainer that you never have. Like some of these people you've never sat in a room with and had these kind of conversations with. So I think it's a pretty cool opportunity. So that's that slide, and then you'll ask them on slide 4. Again, scenarios like this happen. Let me ask you how often this happens to you. You should be at about 10 minutes at this point. Then you're going to go into the next slide. What is TIC? And so the overarching goal of the Trauma-Informed Care Program is to create a system that fosters wellness and resilience for everyone in MMG. That includes both our patients and our staff. It aims to acknowledge the role that trauma has played in patients' lives. And when patients behave in certain ways, we might naturally ask, what is wrong with them? Why is she acting like that? But instead, we want to say, what happened to you? Because that what's wrong can be very judgmental. And that what happened is more of an empathetic stance. Research has shown that the more a person has been exposed to adverse experiences, the greater their risk for serious health outcomes and health risk behaviors. You would ask, and this is a teaching point, ask, how many of you think that if a patient has suffered from physical, emotional, or sexual abuse, neglect, discrimination, and violence, it puts them at a greater risk for depression later in life? Only a few people believe that would impact them later in life. Okay, thank you. I'm like, I'm with behavioral health people, we know. And yeah, it makes sense. It's a common link. Really strong research has shown that exposure to these adverse childhood experiences is associated with chronic obstructive pulmonary disease, heart disease, liver disease, and sexually transmitted diseases. So exposure to adverse experiences is linked to both mental and physical health outcomes later in life. By offering this trauma-informed care approach, healthcare providers can engage more effectively and treat their patients and hopefully avoid overutilization and excess of services. So, trauma-informed care, what is it? Creating a shared language. Trauma, a word that is so frequently used and so infrequently defined. We want to create a shared language. Trauma is defined as an emotional shock that creates significant and lasting damage to a person's mental, physical, and or emotional growth. Trauma can be related to a particular incident, or it can be continuous over months and years. A well-functioning person with a good support system may interpret traumatic events differently than a person who has had challenges, vulnerabilities, or little support in their life. You should be at about 18 minutes. So let's come back to Josie, or Miss Garcia. I invite you to ask yourself what happened to Josie to make her behave this way. So let me give you a few more details. And so in this point in the presentation, I'm going to abbreviate it because I'm looking at time and I'm saying, hey, maybe I emphasized some points too much. I'm going to say, let me give you a little of information about Josie. Miss Garcia has undergone very painful medical procedures since she was very young. Miss Garcia has been unable to find a job and the family is behind on paying rent. She's worried if she misses another payment, she'll live in a shelter. And the last time she came in, the physician was able to see her right away because the clinic was slow that day. Now, we may not know all of this information about our patient, but sometimes asking the question, what happened to make her behave this way, does a couple of things for us. It puts things in a context. It provides a context, and we might be able to understand why she would act that way. It fosters compassion and empathy. It helps us see the strength in the face of adversity. She came. She made it to the appointment. It can help us stay calm, or it can calm us down. And if we're able to stay calm, we're able to respond more effectively rather than having that reactionary question. You might ask, if Josie was your patient in the clinic, what are some ways you might respond that would be more effective? How might you all respond if you knew Ms. Garcia? I'm asking the room. How might you respond? Yes, Kira.
Are you referring to her resistance in the visit right now, or is she, I angry about not being able to be seen yet? Like, I'm just confused about where we're at.
You may not know. I think part of what we talked about earlier is you don't know what's important. She may be angry that the provider was running late and not able to see her immediately. She may be angry because the provider is telling her about insulin and she doesn't want to hear it again. She might be angry about something that has nothing to do with what we can even think of. But how would you respond with a patient who's rolling her eyes and irritated when she's given some advice on how to take care of herself?
I will acknowledge that she's presenting that way. It looks like you are upset based on the way you're looking at me and talking to me right now. Would you like to tell me what happened?
Wonderful. Yeah, so you acknowledge, ask her, what happened? Okay. Validate her feelings. Wonderful. Yes.
What matters to her most?
What matters to her most? I was wondering. I was like, I need to integrate that whole training with TIC. So those kind of questions. So you're starting to get people to move away from what's wrong. Why would Miss Garcia think she could arrive 4 hours late and be seen and think her doctor isn't going to mention her having being in a diabetic coma and going to the ED? Like, what is wrong with you? Of course someone's going to mention these things. But instead, now we're thinking more about how do we respond? How do we have more empathy? And so let's revisit. How would you feel, again, now knowing this and being in that empathetic stance, how might you feel towards Josie? So folks that said frustrated, agitated, thinking about the things that Josie has gone through, does that change any of the ways that you might feel in interacting with her? Yeah, wonderful. And so again, we're gonna ask you to circle those emotions so you can really see that shift. Or if you're short on time, you may just verbally go through it like I did. And so one of the ways, we talked about some things that you're already doing and some ways you might already engage a patient in challenging moments. We have a specific approach to doing that called pearls. Studies have shown that using pearls can decrease cycle time in a doctor's office as much as 12.5%. And so although a lot of you already do these pearls, this is a really quick, easy acronym when you're in those heightened moments with patients to just pull from. So pearls stands for partnership, empathy, apology, respect, legitimization, and support, which can make a huge difference for patients. And so it just kind of goes through the pearls. And then the next point is these are some examples of how to use the pearl techniques. An example of using language that indicates partnership, it's less work together. An example of using respect is you've gone through a lot. Giving support might be let's see what we can do to help. Now if you have enough time, and in the PSR version of pearls, you're actually going to get them into practicing. Okay? So this is a point that you can really dig deep in your clinic and really, this is a manualized approach, but we want you to make it your own. And so in your packet, there's also a hypothetical patient scenario. And there's one based on each of the roles. So if you'd like, you can actually have the providers, you can select one in advance or you can have them pick. And you may say, okay, adult, PCP, we're going to look at the ACEs patient too. What are some ways you could use pearls with this patient scenario? And this is an area of flexibility. You don't have to do this in the training. You can stick to 100% of the script. Or, like I said, it's a great opportunity for you to work with providers. Or maybe there's a specific patient issue that came up in your clinic that recently, that you all could start to work through in pearls. And it makes it more of an alive thing and not just like this boring training that your boss asked you to do, And so that's pearls. And so then we go into slide 13, and we say pearls are tools that we can use when patients are triggered and upset, but what about us? It's not just about patients. I'm going to assume that most of you have chosen to work for MMG or in primary care because you care about humans, you care about people. It's one of the reasons I like to work at Monty. But at the same time, these qualities of working hard and caring about people, we're overworked, we have so many patients, it can be pretty overwhelming. And if we just think about all the things that we have to do, patient phone calls, notes, letters, asking what's important to you, all of these different things can really exhaust us and lead to burnout. And so burnout is the feeling of physical and emotional exhaustion and involves difficulty recovering. This past week I came into my clinic and someone said, and you can use these kind of examples in your presentation. It was 8 o'clock in the morning on Monday and I said, good morning. She said, oh, don't you wish it was Friday? And I said, it's 8 in the morning on Monday. It's a little early to wish for Friday. And she said, oh, just admit it. You know you wish for Friday too. Don't you want to get out of this place? And that's burnout, right? That's burnout. And I had to say, like, I wonder what happened to make her respond that way. I mean, at 8 o'clock, it wasn't even noon yet, to be in that mental space. And burnout is when it's difficult to recover. That weekend didn't do enough for her. She needed another weekend on Monday at 8 a.m. Compassion fatigue is what happens beyond just that burnout. It adds up over time. The patient experiences start to exhaust us, and we keep pushing and pushing and pushing through. I'm on point 6. Without active and effective self-care techniques, it takes a toll on us, both emotionally and physically. In essence, compassion fatigue is the cost of caring. And we start to lose that empathy, that hope, that compassion that really made us become helpers to begin with. It's something that happens to those who are really doing their work well and engaged in the work. And over time, you can start to experience secondary traumatization. You didn't necessarily experience the trauma, but you heard about the trauma and it impacts you. One of the things that we talked about in trauma-informed care is called low-impact debriefing. This is when you are about to tell a colleague something really horrific about a patient and you warn them. So it would look something like this. Hey, Janira, I just saw this patient and are you ready? I'm going to tell you something pretty traumatic. Like it was an intense case. Can I tell you about it? I can? Okay. She might say no. I don't have the capacity to hear that right now. Oftentimes as behavioral health providers, we just go in and go, oh my goodness, Marissa, let me tell you about this patient. She just came in and I don't know what's going on with her. She got her own life, you know, she has her own patients. And so the low impact debriefing gives people the opportunity to brace themselves, anchor themselves, see if they can receive the information and then receive it. Even if they say yes, Marissa's always like, yes, of course. She can still take a breath before I tell her like the worst case of all time. And that's something that can really help decrease the secondary traumatization. Vicarious traumatization is the shift in our worldview. It's that numbness. It's the patient that 2 years ago you would have been super empathetic for, but now you're just like, whatever, that's just what it is to work in the Bronx. It's this persistent sadness, anger, feeling overwhelmed that you just can't quite shake. And you know, thinking about this work, it can be pretty rewarding and it can be amazing, and other times it is more than we can imagine. And the thought that we think we can be immersed in suffering and loss daily and not be touched by it is similar to thinking that we could walk through the rain and not get wet. If you care, you're gonna get some trauma on you. You're gonna get wet. This is gonna impact us. And so we recognized before TIC, everyone was doing this work and they were doing it how they were doing it. But this work is about doing what we're doing in a healthier way. It's about doing this work well while we're actually staying well. And so when we talk about what is the TIC approach, it does 4 key things. Maximizes choices for patients. It catches the often automatic thought, what's wrong, to what happened. When patients become upset, it's using pearls. I'm sorry. It helps them calm down. I empathize. I legitimize. And then it's about taking care of this work after really challenging interactions. It might be taking a breath. It might be drinking some water. It may be a low impact debriefing with your supervisor or coworker. And so now we want to talk a little bit about what does it look like to do this work with our patients. MMG practices universally screen for depression and anxiety across their lifespan. ACEs, or the Adverse Childhood Experiences, is a tool that MMG is using to screen our patients. This means universally that patients from 1 year old of age all the way up to adults will be screened for their adverse childhood experiences. As you've all previously learned through your talent management, ACEs was a major research project. It was a study that found that exposure to traumatic events in childhood is a very good predictor of long-term physical and emotional health outcomes. The study makes it clear that time does not heal all wounds. The ACEs screen asks patients if they've been exposed to any of these 10 events during their first 18 years of life. As you know from your talent management training and from the work that you've been doing at the clinic, we are not asking patients specifically which of the ACEs they've experienced. We're asking for their total score. Each of these 10 numbers are worth 1 point, and so ACEs of 4 or higher increases a higher risk for negative adult outcomes. This is the piece that is specific to our PCP and NPs, and then some of it is in the nursing materials. The PSR one doesn't go as deep. Over time, these changes, these traumatic events, change the cellular level and have a lasting impact. The basic idea of epigenetics is that environmental factors, for example, toxins, viruses, nutrition, can lead to cellular trait variations, which can potentially switch genes on and off and affect how cells express genes. So while the actual DNA sequence hasn't changed, the way the trait is expressed is different. The reason we're discussing this is because chronic stress is another environmental toxic that can have epigenetic effects and actually change how genes are expressed. Without getting too deep into the science, what researchers have found is that one of the reasons that some of our patients may be more sensitive to environments than others has to do in part with epigenetic alterations in the genes that regulate the hypothalamus, pituitary, and adrenal axis, or the HPA, which activates our fight, flight, or freeze. To put it another way, the alterations in the expression of certain genes are believed to result in lasting changes in the stress response before helping highlight the very real neurobiological associations between childhood trauma and a person's reactivity to stress. This change in a patient's physiology not only increases their risk of developing mental health difficulties, but also increases their risk for developing later negative physical health outcomes, which is one of the reasons why we're talking about this specifically in a medical facility. So the dandelion and the orchid. For over a decade, scientists have been studying how present or absent of a gene variant might make a child more resistant or vulnerable to stress. They believe that epigenetic plasticity is important for the adaptation to adverse environments and might help to explain why some children are genetically predisposed to be more resilient while other children are more fragile. This metaphor, the dandelion versus the orchid, illustrates this point. Dandelion children seem to have the capacity to survive, even thrive in circumstances that, whatever circumstance they encounter, they're psychologically resilient. These are the kids who have had horrific experiences and then become an NBA player or CFO. In contrast, the orchard children are highly sensitive to their environment. They appear to be more biologically reactive to their environment due to maybe some underlying epigenetics and temperamental vulnerability. If neglected, mishandled, these children wither, but if they're nurtured, they actually thrive. Any questions so far? So I think this is the content that oftentimes people practice the most. So what happens when dandelion and orchid children as they age with these children? When orchid, I cannot say that word today. Orchid, thank you. I'm like, that word is not coming out of my mouth. Orchid children are exposed to chronic stress and trauma. Not only just mental stress, but their physical health outcomes are worse than their dandelion peers. However, these children, when they're given support, their health outcomes were better than their dandelion peers. We think this is pretty important to point out because these aren't children that are just vulnerable. They're also children that will thrive when they're given really good resources.
Can you say that again?
Say what? So both of you said two things at once.
I was asking for the orchid kids, give examples of what are some supportive examples that help them to thrive?
Yeah, so maybe an orchid kid, if they were given an after-school program, if they were involved in healthy steps, if they had maybe food support programs like social determinants of health, that those kids respond very well versus maybe a dandelion child who doesn't have these supports and is in a house where they're watching TV all day and they still are able to thrive in that environment. Katie?
Yeah, the orchid children also, when they're shown to have at least, even if it's just one adult who cares for them and believes in them, they can have all of the impact. And that one adult doesn't necessarily have to be the adult that's in the home. It could be the doctor who stays with that child throughout their life.
Or the social work.
Or the social worker doctor. And then you had another question? Or was your question answered? Okay.
I think that's called protective factor.
It is protective factors, but it's how people respond to these protective factors that are different based on that epigenetic risk factor and vulnerability. And so part of the reason why that's really important, because as we talk about distribution of resources and how people respond to those resources, how they respond to trauma. So if a dandelion child comes into the clinic and they're now an adult and they're in an environment and the clinic is super loud and maybe the pediatrician and their child is running 2 hours late, they'll go get some food next door, come back. An orchid, and I have orchids all in my house. This is evading me today. An orchid child comes into the clinic and it's loud. They might have a full out tantrum and have a really hard time with that. And it's that vulnerability that is different. So why is one child responding this way and another responding a different way? And so we talked a lot about trauma-informed care and this idea of doing this work well while staying well. And while we focus specifically on our patients, we also want to focus on our staff. We have some resources here, and if at this point you're done and your time is up, you would stop at this point. However, if the people you're giving the presentation to are very engaged, you might end with a mindfulness activity for them. And so they have the resource list, and this is also in their handout. In your handout packets, it'll be stapled to their handouts. At the end, you can do 3 minutes of relaxation. I know that my clinic loves some guided relaxation. They're all about guided relaxation. You may not have a clinic that's engaged in that way. It really just kind of depends on the staff. And so we have a 3-minute script that you could do with them if you have enough time and if they're interested. So that's the presentation. This one is probably the most challenging in terms of the amount of detail. And the rest become less and less detail as you progress. Questions? So you would be giving the exact same presentation I just gave in your own way, in your own words.
So you mentioned about the hypothetical patients. So that's something that we would choose to incorporate depending on the situation or depending on the time flow.
They mean you as a trainer? Okay. So the trainer, you would decide if you want to use that hypothetical at that point that I had given during the presentation or not. In advance, you should probably have read the hypotheticals and kind of know which one you feel most familiar with talking about, and maybe which one seems most similar to your clinic, or have a case in mind if you decide that's the approach you want to go, just to be prepared.
So I assume that I'm going to be doing everyone together because Riverdale is a really small site, 3 primary care doctors. So how much of the science there's more PSRs than doctors.
So the combined version is the middle ground between the PSRs and the doctors. So it's kind of like the nursing version. So some of it will be above the head of maybe some of the PSRs, not all, obviously. And then some of it will be too watered down for some of the docs. It's the middle point of the presentation.
And that you're going to send out?
Yes, but it may not just be based on your site size. It has to do with when they're available. So at the smaller sites, sometimes they're not interested in the entire, because it's only 3 people in one PSR, they can't have everyone not seeing patients for an hour.
Right.
Versus the larger sites, they may have that ability. So it's not just based on size. It also has to be it has to do with what the administrative director says are the times that they have. Other questions? Yeah.
Is it okay to use Nadine Burke's TED Talk?
It is. Most sites don't have that level of technology to show the video and with the sound. Also, we require, because all of the material here you need to present. If you kind of gloss over some points, fine, but all of the slides need to be presented, and it's done in a time frame. So if you add that video, you would have to figure out how to incorporate that time. Maybe your site will give you additional time. It just kind of depends.
She talks about that plasticity and the brain and blah, 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 all the, technical, medical piece. When I did it at Wakefield, I found that it intrigued the PCC. It got.
Yeah, that's why we added this content, because we got that feedback that the PCPs wanted more brain and science technology. So that's why we added this piece. But then a lot of the sites don't have. We didn't want to set it up in a way that people don't have the technology. Yeah.
So I'm tempted to want to add a little bit in terms of, we've been at Ambassador Avenue and we've been doing the ACEs screening, but we're still having kinks in terms of the way that it gets documented in Epic, and I think also I would be tempted, so I'd want to talk about that a little bit more, and I want to talk a little bit more with my doctor too about, like, if you have a score of 4, how to talk to patients. Could I do that as part of this training? Or
I wouldn't recommend that. So there's a point in the PowerPoints that says that's something at the transformation meetings and that you're working with the team. Part of the concern that we have is sometimes our staff don't have the knowledge of the ACEs and want to move to the next step. And we really want them to understand it, not only from a patient perspective, but a personal perspective. And that oftentimes will guide the way that they're interacting with patients. We invite you to continue to have these conversations. If your staff wants a specifically formulated ACEs PowerPoint presentation, we have those resources. This is the only training that you have to do unless your site requests additional trainings. For the first wave, I think we did 4 of these different versions, and now we've combined all the information. So you all looked out. And it was 4 individual trainings like this, unique ones, and one of those is ACEs. So we can go into that as well if they're interested in like helping with the rollout. But our hope is, because the goal is to create shared language, if your site has one type of training and then a doc goes to another site, there's not a universal educational approach. Okay. Other questions?
Just a quick question about, in terms of like from here, I'm thinking about the acronym PEARLS and the fact that it may be wise, I know for myself, when there's an acronym and it's new to me, I like having, let's say, like a little visual that would sort of cue me to it in the future. Are there like visuals that go along with it that could be pasted up, in the PSR section, or for a doctor, for me, to remind myself, what does PEARL stand for again, and what are the different questions I could go to?
Yeah, your site, you're welcome to develop those tools, or for your site to laminate and create those kind of things. Every site is a little bit different for what they want. I'm going to send this electronically, so you have this, and then you also have those materials. Some sites don't post a whole lot of things. We recently asked sites if they wanted to do ACEs posters. We have all these beautiful posters about behavioral health. Some sites wanted itty-bitty ones that they just put at the front desk. Some sites wanted posters for every single room. Some wanted huge posters. So we just leave that up to the creativity of the MMG sites. Other questions? Yes.
Orchid children, because at first I myself had a little difficulty like thinking of a picture. When you said that threw me off a little bit, but then I realized, oh, a dandelion is, some people eat dandelions, for them, they're like an orchid, but I don't know.
Can you belong to both?
Or the assessment of the criteria.
So it's a metaphor. It's not necessarily like we don't have a screener like you are officially a dandelion child. It's just, and I think the metaphor can be, yes, I think the metaphor can be fleshed out. You can Google this. They have YouTube videos on this. It's a metaphor that's very common in the medical field and specifically in trauma. Our goal, though, because one of the things that I said at the beginning is that you might have to cut people off. We want to keep it within that time frame. So if you go too deep, too long, like you will go over time. You will not get through all of the slides. And we have promised our sites that it's going to honor the time that they have because they are not seeing patients for an entire hour. That's a long time. And so we really try and skim the information down to like the bare bones. And they've received all of this information already in the talent management. This is the second time they should be receiving this. So there's a whole video that has gone through all of that is given that information. You should have if you sign into your EasyPass talent management, you have the option of doing any of the modules yourself and it'll go deeper into that information as well.
So from Pearls, one of the things I see, I can imagine getting a lot of resistance from the PSRs in Riverdale is the apology piece. How would you respond to that? Because I think that may be.
So Pearls are multiple tools, it's multiple letters. You don't have to use every single one of them. If that feels like something you're not comfortable with and you can't authentically do that, I invite you not to. The way that you give an apology, it can be like, well, I'm sorry. Or it can be like, I'm really sorry that happened to you. And like some people are not people who apologize, but they can be reflective and they can use some of they can partner, let's see what we can do to help you. And so they don't have to use every single one of the Pearls. How many of us use every single one every single time? It's flexible. Yeah.
You know what I will add to the employment assistance program that is really, really good is the healing and loss workshop.
Okay, wonderful. So that might be a handout that you share with your clinic that you can talk a bit more about your experience or what you know about that resource. Definitely.
Somebody had the same question here on this side that Joyce had, and I think as presenters, it's good for us to feel confident about those two topics. And we were just talking, I thought you were done, so before we were just talking about orchid kids, the question was, what were the signs of the different, and the orchid kids, they could be like, lashing out or acting out or not doing well in school, or they could be trying to use drugs, or they're just not, they don't have the support system that a dandelion kid would have. So like as a social worker, we're trying to link those orchid kids with some resources that can help them do well, in the time to come, in the months to come, but the dandelion kids have the resources.
Or they may not need them.
But they're thriving. But they're doing well in school despite the fact that things are going on in their environment that are not positive. So that's what we were talking about earlier. And I think as presenters, if you're presenting, it's good that you're confident about what these topics need.
I agree 100%. And I also want to keep in mind that we're not training social workers. We already know this stuff. Some of it may be new, but this isn't a training specifically for us. I know I've presented TFCBT and other trauma presentations in this community as well as our own. That's a deeper dive. And so I know that like your BHIP lens is like really wanted to like explore that concept and go all into like resources and all of that. The PCP has 15 minutes. They're not going that deep and they're looking at 15 other different things. The PSR is not going that deep. The nurse has a short amount of time. And so it's also recognizing our audience. You know more about trauma than anybody who's going to be in that room. And I definitely hear the epigenetics and wanting to know all of the epigenetics and all of that detail. I think that would be a great training for us specifically. But I don't necessarily think that level of detail you're not going to have the time, and the PCPs do not have the time in their appointments, nor do the nurses or the PSRs. You want to give them enough information that they can use it, that's going to impact their practice, but not to the point that they feel like they're at specifically our grand rounds and now they have to become a social worker. Now they are a psychologist and they're getting CMEs and now they're boards and they're taking their life. Like that's not their role. So I think that's just an important thing to think about because we also have a very short amount of time. And that was a lot of material and I spoke really quickly and I didn't even go through every single point. And that was without anyone sharing and giving points and saying, oh, this is how I feel in their stories. So even though it might feel like, oh, she went through it in 35 minutes, that's gonna go by so quickly, okay? The other question?
Just a quick question about for the epigenetics, because I'm guessing that the docs, I'm guessing that this is something that's talked about in medical school. Like this is actually more new to us than it would be to them. I'm thinking, like, when people have presented in the past, are those things actually something that's kind of like a quick review for them?
Yeah.
Because I'm guessing, like, for me, not thinking about that, I might be tempted to be like, let me explain because to me it's something newer, and so I might be tempted to kind of present it as something new that they're learning now versus something that actually they already probably know, and we're kind of reviewing with them.
It was the cover of Time magazine.
Right.
You know, so it's not just us. I mean, this is popular knowledge that is becoming more and more popular, and it's going to be somewhat of a review, but it also puts it in a context. So all of these terms, a lot of the things that I said today, you didn't go, oh, trauma, what? You know, it wasn't new. This isn't new information. It's about putting it in a context of how we engage and think about our patients. If you're looking at a kid and saying, oh, look at that dandelion, you better rock it out. You know, like that is a different lens. Even if you're already thinking, you know that information. How does Time magazine have to do with your 15-minute visit? It might have to do with why that kid is in the corner screaming, and maybe why you might need to go and see that kid first and get him out of the room versus another kid who can wait. That's going to inform practice. And that's the big point. So I don't want us to get lost in the weeds or in the dandelions of this, is that the big point is that the work that we do is hard. Our patients have experienced a lot of trauma. Working with people who have experienced trauma can be traumatizing, and we want to be able to do that work well and still be healthy, sane, wonderful providers. That's the summary. That's the point, that if things get off point, you want to keep driving that home. Because that's what the bottom line of it is. If you're a dandelion, if you've had 10 ACEs, at the end of the day, it's about what do I do when you're in front of me to engage you in a way that does not re-traumatize you and does not traumatize me. Isn't that it? Right? Okay. So Alyssa is going to do a brief presentation on how to be an effective trainer, and then we're going to practice. So in your training materials, Alyssa's going to be speaking from the handout that is in that packet that's in that first training materials.
What you've had the opportunity to see this morning. Oh, I need the thing.
Oh, that's my badge. We look a lot alike. Here you go. Okay.
Just not pregnant.
That's the only thing.
I'm thinking to myself, she looks just like my stepfather.
I'm going to just hand this.
Okay, thank you.
Clip on.
And I'm happily not pregnant.
Yeah, I'm with you on that too.
Okay, can you hear me better now, Katie? Okay, so what you had this morning was two really good examples of effective training, right? You had Damara and Joan, and you just saw Dana, okay? So in the handout, here's the deal. Not everybody feels comfortable talking to groups. If you're going to do the training, you have to get through it, okay? And you don't need to share with the group, I'm not a good trainer. You don't need to say, I'm really shy, this is really hard. You just need to get to the material and go through it and stick to it, okay? So, nonverbal communication. So I stick this in my pocket, okay? Nothing worse than a trainer. Sorry. Nothing worse than a trainer that does that in the middle of the training. Okay? So you want to be personable, nonverbal cues. You want to be personable, you want to be a good listener, you want to be energetic, but like not over the top energetic, because remember, you're training about trauma, so you're not coming out with pom-poms, because it's incongruent to the training, right? Think of Damara and Joan this morning. You walked into like the happy songs. Do you imagine bringing that song into like a trauma training? People would think there was something wrong, okay? You want good eye contact with your audience. That's the hardest thing because that's where people's shyness comes out, but you really want to try to make eye contact with every single person. Okay? Doesn't matter if they don't want to make eye contact with you, but you want to make eye contact with them. And you want to walk around the room. You saw Dana walking around the room. I don't stand still. I had a professor who once said, if you don't walk up and down the rows, you're going to lose the people in the back. So if you're standing, you're going to walk around. If you're sitting, don't move. And you'll, listen, it depends how the room's set up. I just did a training at FHC. I was like shocked when I walked in and there were like rows of chairs and a screen. I thought I would be with a circle. Okay, and then I just did a training at CFCC and we just sat the entire time. So you need to know what the room looks like and set it up to in the way that best fits the room, best fits the culture of the site, and best fits you as a trainer. You want to know your material and know where you're uncomfortable and comfortable. So this dandelion orchid.
Orchid, I know.
See, we really are related. This whole thing, don't go off on it, right? Be concise. Dana has prepared the slides. You know that the trainings you've gone to, where all of a sudden there's like all this diffuse information, you stop listening, right? So stick to the slide, be really concise, practice your material before you go. The content skills, be prepared, be concise. Verbal skills, project your voice, your tone of voice. There's nothing worse when you can't hear somebody speaking, right? Or they're like, the affect is incongruent. We're going to talk about trauma. No, okay? If you are not humorous, do not use humor. There's nothing, Dana's funny, okay? I'm idiosyncratic. Some of my students have said, now you guys know I teach. I'm faculty, you guys don't know that. Some of my students say she's quirky, some of them think I'm funny, but I'm not funny about really difficult things. And if you're not funny, or people don't laugh at your jokes, or you're the only one laughing at your jokes, don't use humor.